Bugs Without Borders, next on International Focus.
The Institute of World Affairs at UWM and Milwaukee Public Television present International Focus, a global magazine linking Wisconsin and the world.
Welcome to International Focus. I'm Doug Savage, Assistant Director of the Institute of World Affairs at UWM. In an age in which the most distant corner of the globe is less than a day away, a disease outbreak in one place can quickly spread, setting the stage for a global pandemic. As recent incidents involving SARS, avian flu, and H1N1 illustrate, it's truly a small world. The ease with which pathogens make their way around the world has placed a heavy burden on health officials charged with keeping local populations safe. Here with a report from the front line in the battle against the world's bugs, we're pleased to be joined by Paul Biedrzycki, Director of Disease Control and Environmental Health for the City of Milwaukee Health Department, where he's been active in the planning and response to a number of emerging infectious disease events. He also serves on many regional and national boards involved in the integration of public health within Homeland Security and emergency preparedness. Paul, welcome to International Focus.
Thank you, Doug.
Well, I wonder if we could start with just some basic terms. We hear epidemic, pandemic, outbreak. If we could just look at each of those in turn and see from the practitioner's perspective what each of them mean.
Sure. Epidemic generally refers to an outbreak of disease, much more local or regional, where we see the incidence of disease or occurrence well above what we see in the background. A pandemic refers to a global epidemic, and certainly we've seen that most recently with H1N1.
And typically, are these naturally occurring phenomena, or are there man-made incidents?
Well, epidemics and pandemics in the 20th century are mostly naturally occurring and still continue today. But of course, post 9/11, we still have the threat of bioterrorism. And so there is concern about man-made epidemics and pandemics occurring.
What about sort of inadvertent man-made kinds of things? I mean, I'm thinking of H1N1, for example, being traced back to Mexico, and there were some people that said you could even trace it more specifically to sort of factory farming kinds of operations where animals are living in much denser circumstances than they typically would. I mean, how much of sort of modern agricultural practices have contributed to this?
Well, certainly that is a consideration. I think, again, highly populated, densely populated human urban areas combined with close proximity to animals can create, again, the ingredients for regional epidemics or even pandemics. It's not certain exactly how 2009 pandemic H1N1 originated. We do think the epicenter was somewhere around Mexico or Mexico City, and we do know it involved, again, an unusual novel strain of swine origin. But you're absolutely right. The nexus of humans and animal populations can create, again, the necessary ingredients for local epidemics and worldwide pandemics.
So I assume there's something bubbling in many parts of the world at any given moment. How is that monitored? I mean, from your desk here in Milwaukee, what do you do to keep an eye on what might be the next thing coming down the road?
Well, it's monitored by in a number of different ways by local public health officials, certainly through communication with state health officials and then upward to the Centers for Disease Control here in the United States. But also the World Health Organization and CDC have a very active international surveillance program that keeps an eye on zoonotic diseases, emerging human infections.
And zoonotic is?
Zoonotic refers to diseases of public health importance that originate in animals, wild or domestic animals. And those are looked at very closely by the World Health Organization and CDC, and that intelligence or information then is streamed back to state and local health officials.
So, I think we can sort of imagine the chain of organizations within the U.S., but say something has its origins in China, for example. So the epicenter is a village in western China. How does it first become on the international radar screen?
Believe it or not, it's from astute clinicians in that locale. It's individuals becoming sick, generally in clusters or unusual number of cases, that come to the attention of local health officials or province health officials or state health officials that then would report this up to the World Health Organization, who is closely tied into the Centers for Disease Control, and will actually send teams to investigate, validate the level and type of illness, and then refine that intelligence stream back through international, national, and eventually local systems.
So we'll assume the best intentions on the part of healthcare practitioners. Are there any sort of political considerations that can impact that system?
Oh, absolutely. And there was lots of criticism of the Chinese government in the 2003 SARS outbreak of not being very forthright and upfront in terms of the amount of illness they were seeing, where the illness was geographically located. Some of that's been smoothed over now. I think there is better international cooperation in terms of reporting disease, because we're all in this together. And these bugs, as we know, don't observe jurisdictional borders. And in today's day and age with globalization, they can travel quite readily across the globe in a very short period of time.
So where we've had pandemics in the last, say, half a century, do they tend to catch organizations like yours off guard, or are there things that we can sort of see developing and have a little more lead time?
Well, we were overdue, some people would say, for a pandemic here in the 21st century, and H1N1 turns out to be the first pandemic in 40 years and the first of the 21st century. In some ways, we were planning for a pandemic. We were planning for a pandemic that involved H5N1, a different type of novel influenza, and instead we got H1N1. So the severity of the pandemic kind of caught us off guard, as well as its occurrence in an economic recession. And we didn't calibrate our plans very well to accommodate, again, the economic and social disruption that generally is associated with response to pandemics, even here in the United States, much less developing countries. So again, we were anticipating a pandemic because some people felt we were overdue, and so we had plans in place. We need to refine and recalibrate those plans as part of lessons learned from H1N1.
So how is it that we were overdue? I mean, is there a sort of a natural cycle for things? Or?
There appears to be a natural cycle, and again, no one knows with certainty, but if you examine the last 3 pandemics of the 20th century, they were spread apart by anywhere from 30 to 40 years.
What would those be?
Those were the 1918 Spanish flu, which was the granddaddy of all pandemics, very severe morbidity and mortality. The 1957 Asian influenza outbreak or pandemic that really didn't take as large a toll as the 1918, and then followed by the 1968 Hong Kong flu pandemic. And you can see those last 2 pandemics are separated only by 10 years, which is somewhat surprising. But again, we feel that these pandemics are generally naturally occur over a period sometimes as short as a decade, maybe as long as a few decades. And here we went 40 years without a pandemic, but we did follow many novel influenza strains prior to this one bursting on the scene globally.
And so are there certain conditions you can see aligning that would say, oh, one's about to break? Or?
It's very difficult. There are 3 characteristics of these novel viruses that define them as a pandemic. One, they need to be brand new. And again, why we refer to them as novel, where everyone by definition would be susceptible. No one would have ever been exposed and would be immunologically naive to that virus. Secondly, they have to result in severe infection in humans, and certainly H5N1, and to a certain extent H1N1 for certain portions of the population results in very severe illness. But probably the most important is ease of transmissibility. And once these viruses become very easily transmitted, generally through airborne routes, it's a respiratory infection, they meet the 3 criteria and kind of explode on the scene very rapidly and readily, and are notoriously adept at changing, either arbitrarily or very quickly, which really is a challenge for public health officials.
And is there anything in sort of pandemics going forward that's different in terms of social conditions? I'm thinking of just the degree to which people are traveling internationally, which might not have been the case in some of the earlier pandemics?
Well, certainly the globalization, both the global economy, the global market, the way people work, live, and play across states, across countries, really has changed the complexion of how quickly these bugs can travel. And if you even look back at the 2003 SARS outbreak, we saw the beginning in a hotel in Hong Kong, in a business class hotel, spread to a number of business travelers, a small cluster, and then around the world in over 9 countries within 48 hours, which was remarkable and a big lesson learned by public health officials in terms of international cooperation and communication, which is needed, again, to prepare communities and mitigate the overall health impact within those communities quite rapidly.
So let's talk a little bit about SARS. That was an interesting case. What was the sort of international down to national, state, and local response? I mean, if we could trace that a little bit. I mean, we see something is going on in Hong Kong, and how does it eventually get to your desk?
Well, for SARS, it was very, very unusual, in some ways caught us off guard of how quickly this virus emerged. I think the etiology of the SARS virus wasn't well understood in those first few weeks in which it kind of exploded on the scene. We did see severe respiratory illness in a wide range of individuals, not specific to an age group, but individuals that would generally be considered healthy, suffering from pneumonias and acute respiratory disease. We weren't certain as to the etiology of the coronavirus, which was somewhat unknown to us. It's in terms of its reservoir or origin. Later on, we found that it was traced back to the civet cat, an exotic feline species in southeast China, and used for trading and swapping and eating. We were caught off guard with how readily this virus spread, especially through fomites, through environmental surfaces, and it was isolated later on keyboards, on computer monitors, on doorknobs, on carpeting, and was still long-lived on those surfaces and was easily transmitted, especially in healthcare settings. And the healthcare workers took a significant toll with the SARS virus. So there was a lot we didn't know about the etiology. There was a high case fatality rate, a lot of severe morbidity. Healthcare workers on the front lines were becoming ill, which is very disconcerting for public health officials who rely on them to deal with the surge of public who might become ill. And so there, again, a lot of lessons learned. Communication primarily occurred through the World Health Organization to the CDC, to local and state health officials in the United States, as well as in countries worldwide, fairly rapidly through internet communications, teleconference and video conferencing capabilities, that many were being tested for the first time for this level and type of outbreak globally. And then this outbreak, or global outbreak, kind of disappeared for reasons we quite don't understand. It was quenched. The virus was either suppressed or burned out after running its course through the population for, again, reasons we don't quite understand. But again, lots of valuable lessons learned, some that have been embedded in pandemic influenza planning today.
Well, great. Well, we're going to take a short break. When we come back, we'll have more Bugs Without Borders on International Focus.
The Institute of World Affairs presents our community with a range of public programs relating to global issues, U.S. foreign policy, and the world economy. For more information about the Institute of World Affairs, call 414-229-3220 or visit our website at www.iwa.uwm.edu.
Welcome back to International Focus. We're talking with Paul Biedrzycki from the Milwaukee Health Department. Well, let's talk a little bit about the run-up to the flu season. We're currently just finishing. The reports in some quarters of H1N1 were almost apocalyptic. I mean, we were told to expect really, I think, much worse results. How did that sort of run-up play out in your office? I mean, what was the first inkling that this was a real concern, and what were sort of the discussions and decisions made in terms of the response?
So news came to the Milwaukee Health Department, as it did many local health departments, through information from the Centers of Disease Control indicating the emergence of a new virus, a new influenza virus that was isolated in 2 children in counties surrounding San Diego. And that came in mid to late April, followed by additional reports of children with identical strains of this virus in counties surrounding Dallas, which tells a local public health officer like myself that this is pretty widespread, especially if these children aren't epidemiologically linked. Dallas and San Diego are separated by at least 1,000 miles, so I'm thinking in a short period of time this virus either traveled very quickly or is circulating in a widespread manner. The Milwaukee Health Department, as did many local public health departments, enhanced surveillance, active surveillance for cases of influenza-like illness, individuals presenting with fever, with cough and sore throat, especially if they had travel to Mexico the previous 7 to 10 days.
So how does that surveillance work, for example? I mean, if I go to my doctor with a sore throat and a cough, I mean, how does she know to report it to you?
So the alerts go out really to acute health care centers and hospitals pretty quickly, right from the Milwaukee Health Department, and we rely on the network within managed care to spread that out to their providers, to report that information to a central location, either in the managed care organization or right to the local health department. In a short period of time, we accumulated over a couple hundred cases of influenza-like illness involving travel to Mexico that met what we call the case definition. And through laboratory testing right here at the Milwaukee Health Department, along with other labs in the community, specifically out at Frederick and Children's Hospital, we were able to isolate unsubtypable type A swine origin influenza that was later confirmed by the Centers for Disease Control. And so pretty much that's how the system works early on in any type of outbreak. You want to establish a case definition, put the alert out to providers, have them report back, and you begin to characterize the magnitude and transmission of the disease within the community. We call that the epidemiologic curve. For the second phase, we were more interested knowing that it was widespread, and the second wave of influenza occurred roughly beginning September through December, January of this year. We're more interested in characterizing the severity of disease, who is actually becoming most ill with the disease, who was becoming hospitalized, who was admitted to ICU, and of course who presumably died, or where the virus was implicated directly or indirectly in the death. And so we spent a lot of our time characterizing severity as well as genetically characterizing the virus to note if there were any mutations or changes, especially those related to susceptibility of Tamiflu, or to see, if, again, if it changed significantly from the vaccine that was being used, which was developed as a result of the first wave. And so you can see the complexion of our response and our interest in the virus changes from characterizing its presence, its magnitude and transmission in the community, to then severity, its susceptibility profile, and then evaluating our interventions. And our interventions in the spring were primarily social distancing, having people observe good hygiene, good cough etiquette, staying away from other people that weren't ill if they were experiencing symptoms, so staying home from work or school, and again, monitoring illness within the community. For the fall, it was about pushing out vaccine, which is the primary preventive measure, and ensuring people had access to vaccine, as well as these other non-pharmaceutical interventions of social distancing and hygiene that need to continue to occur.
And, I think we have some sense that the vaccine is different every year. Could you talk a little bit about how that happens?
Yeah, the vaccine needs to be changed every year because the virus changes ever so slightly every year in a phenomenon known as antigenic drift. So flu viruses are notorious again for changing. Novel flu viruses are very prone to mutation, but even seasonal flu viruses acquire new genetic material each season as they burn through populations and meet new types of people, so to speak, and hosts, and change ever so slightly, which makes the previous year's vaccine less effective. And so we need to manufacture a new vaccine each year, and we begin that process generally in February or March, right about now, based on the prevailing strain overseas, which kind of makes a circuitous journey across the globe from south provinces of China all the way through the southern hemisphere and finally to the northern hemisphere in about fall.
So there's a typical sort of geographical path?
There is for reasons we don't quite understand, but we follow that very carefully. In some ways, it's a guessing game. So we look at the prevailing strain in China right now that's originating. Generally, flus originate of public health importance in waterfowl, and waterfowl that come in contact with chicken or other types of avian species. That's how these flus really begin, travel the globe, and then eventually make it here. And we always hope that they haven't mutated or changed significantly, so the vaccine we begin to manufacture right now for next fall is very effective. We refer to that as a good match. And so every year we're faced with that decision right about now. What strain will be the predominant strain for the coming flu season? Because vaccine takes right now about 4 to 6 months to manufacture. And we're getting better at doing it. We're hoping that cell-based technology will allow us to shorten that time frame by literally months. So right now, about 4 to 6 months to make vaccine. Cell-based technology, think 3 to 4 weeks. And we're also looking at making one vaccine that covers many different strains. Right now, we need to make vaccine that covers what we consider the 3 predominant strains that would emerge, 2 type A strains, 1 type B. So there's a lot of guesswork
done. For example, this year we're encouraged to have our typical seasonal flu vaccination and then a separate H1N1.
Because the H1N1 emerged after we began production of our seasonal flu last year, and we couldn't build it in the seasonal flu vaccine. This year it has been rolled into the 2010-11 seasonal flu vaccine. That announcement was just made by the Centers for Disease Control a few days ago. So we know there'll be a H1N1 swine origin variant in this coming, this year's flu season. And we're hopeful that many people will come out to get that vaccine because it'll be very protective not only for H1N1, but any other seasonal flu strains that might be circulating as well.
And what about that in terms of, you can do your response, but at some point it's up to the members of the population to then follow through. What are some of the factors you see in compliance with getting immunized?
And you brought up a very good point. It takes the community to protect the community. And when it comes to public health, it just isn't the responsibility of one government entity to do that. So again, we generally hope that people would be very compliant with vaccination, but we've seen a growing trend of an anti-vaccinationist kind of movement or trend, especially with young parents, whether we're talking childhood immunizations or flu immunizations. And most of that is based on concerns about safety of the vaccine, its links to autism or the preservatives that have been used typically in vaccine, many of which have been removed now because of those concerns, even though there has been no compelling scientific evidence linking preservatives in vaccine or vaccination in general with any of these types of disorders, autism or any other types of illness. Now, there are side effects associated with vaccination. Generally, we see side effects that are very minor, like swelling of the arm, soreness or redness or tenderness in the point of injection. Sometimes there's a slight fever, but that's generally relegated to less than 1 to 2% of individuals getting vaccinated. So even though there isn't compelling evidence linking vaccination to any serious types of disease, chronic or acute, we still see a growing trend where people are opting not to get vaccinated, which really creates a change in the immunity of what we call the herd, our population. And as herd immunity wanes, our vulnerability to all sorts of other diseases increase, including some of the most common vaccine-preventable diseases like measles, pertussis or whooping cough, and mumps. And we've seen national outbreaks over the last 5 years in each of those categories.
Wow. Well, we've got just a few minutes left, but one area we haven't touched on is how food safety plays into all of this.
So food safety and security is of big interest these days because of natural occurring bugs that are adulterants in both fruits and vegetables and meats, quite frankly. And it all began with the Jack-in-the-Box hamburger outbreak back in the 80s, where E. coli 0157H7, an emerging pathogen, was linked to many severe cases of illness and many deaths, actually, from consuming undercooked or raw meats.
Is this largely a domestic phenomenon, or can these foodborne pathogens be found in food that we may import from elsewhere?
Absolutely. And in fact, the global food chain now really requires us to be more scrutinizing of what's coming in the country. And quite frankly, the FDA and USDA just don't have enough staff to conduct that level of surveillance right now. And so I think we're at a very vulnerable period in this country with regard to the farm to fork food system that we enjoy.
So in the international system, we're largely dependent on the exporting countries' controls over the health of their food.
Absolutely. And there's talk now of just developing a registry of who's making food worldwide and then limiting what can come in this country. And again, it creates a lot of consumer issues as well. We enjoy our fruits year-round now, especially in a climate like Wisconsin. We like our Chilean nectarines in the middle of December and January. This could limit the availability of certain types of foods that we can find, again, or that we enjoy right now year-round.
Well, and I can imagine there'd be a few business interests that would have something to say about that.
Absolutely. There are economic impacts to all of these policy decisions, public health policy decisions.
Well, we've got less than a minute left, but any advice for our herd before we go?
Get vaccinated. We're seeing H1N1 still widely circulating in the community, although the levels have dropped significantly over the last 4 weeks. We're not seeing the appearance of seasonal flu for reasons we don't quite understand, but it's still not too late to get vaccinated. It's in plentiful supply, and it will not only protect yourself, but transmission to others, especially the most vulnerable in our community. Young children or people with underlying chronic health conditions are especially vulnerable to H1N1 influenza.
Well, Biedrzycki, we'll leave it at that. Thanks for being with us. To our viewers, we'll see you next time on International Focus.
For information about the Institute of World Affairs and its many programs, or to become a member of the Institute, call 414-229-3220 or visit us at our website,